My name is Sarah Zietz, and I work in marketing here at Sports Health, a division of School Health Corporation, and I will be today's moderator. First of all, I would like to thank you for joining us today. We are excited to have Dave Hadley here to talk about ECG screening and his unique product, CardeaScreen. But first, I would like to go over a few things for today's webinar. We will not be taking audio questions from the audience, but we would like you to type your questions into the questions interface in GoToWebinar. You can submit your questions anytime during the presentation, and we will plan to address them after Dave is finished presenting. Dave will take about 35 to 40 minutes for his presentation, leaving time at the end for the questions. This webinar will be recorded, and a link to it will be posted on the sportshealth.com and schoolhealth.com website after the webinar, and it will be emailed to you for future playback. You can expect that email in about 5 business days, and please don't count Thanksgiving and Black Friday towards those 5 business days. We also like to eat turkey, watch football, and go shopping over here at School Health. So probably Monday, December 1st, if not sooner. Everyone who attends today's webinar will also receive a certificate of attendance for joining us today, along with a copy of the slides. And during today's presentation, we are going to launch 2 very quick polls to ask our audience to participate. So look for those polls, and if you can make your selection, we will share the results with you right away. And now I would like to introduce today's presenter. I'd like you to meet Dave. Dave holds a PhD from the California Institute of Technology. He spent 9 years as Vice President of Research and Development for Quinton Cardiology, and he is an inventor and patent holder for CardeaScreen. He has also been a board member, past and present, for the University of Washington, Harborview Pacific, and the Pacific Northwest Ballet. Most importantly, I can tell you firsthand that Dave is passionate about preventing sudden cardiac arrest in young athletes. And today, Dave will go over why ECG is such an important tool in preventing sudden cardiac arrest, and also why CardeaScreen makes it easier than ever to add ECG to your pre-participation exams. And with that, I will stop talking, and I will hand it over to Dave.
Thank you, Sarah. Appreciate the introduction. I think we start first with a seminal event with the death of Hank Gathers back in 1990 that brought national awareness of the issue of sudden death in our athletes. For those of you that have seen the replay of the sudden death on the court, it's quite a tragic and moving moment. But it hasn't been just the Hank Gathers. It's an event that happens way too many times to too many young youth at the time when they're in their peak health and the point of their most or best part of their lives in athletes. Today, recently, a group of cardiologists at a national meeting were asked how many of them would support ECG screening. A total of 60% thought that ECG screening should be a part of our pre-participation exams. And the remaining 40% tend to feel that there is still insufficient data to support ECG screening. But if we look at what the recent and current advances have been in both technology and standards for ECGs, we're seeing that the cardiologists are rapidly moving towards the view that screening is here today and it should be done. So today we'd like to talk about some of those advances, why ECG screening is effective, how you might implement it in your institution. We'll talk about the risks that athletes face, why they have those risks, what's preventing us from doing a good job today with our current practices for physical exam and history. We'll talk through some breakthroughs that really enable ECG screening. And then from there, we'll move into talking about how to add an ECG to your pre-participation exams or your athlete physicals. And then finally, we'll close on why is CardeaScreen the right device for you guys to use as you do your screening of young athletes. So I think with that, we're going to ask the first poll. Sarah, can I have you go ahead and launch that? So please indicate your role. We'd be very much interested in what role you play in the management of health and your athletes.
Okay, it's launched, and the votes are coming in. We'll give it just another minute here.
Okay.
Okay, I think one more moment. Okay, so I'm going to close the poll. If anyone else wants to vote, vote, and I will close it. Okay, and then I'm going to share the results here.
Great. So we have a large population of trainers and school nurses. Welcome. This is tremendous. Okay, let's go back to the presentation. So these are our topic areas that you saw on the announcement for the webinar. We'll start with the purpose of the PPE, or the pre-participation exam. We'll talk about abnormalities in young athletes by demographics and sport that can lead to sudden death or sudden cardiac arrest. We'll discuss in further detail why the current practices in the physical exam and history don't identify at-risk athletes. Some very exciting changes that have been happening over the last year or two in criteria for screening athletes, and we'll talk about what those are and what the implications are for effectiveness. And then finally, we'll talk about how to add an ECG to your pre-participation exams and why CardeaScreen is the right choice to help you make that done or accomplish that effectively. So when we think about the pre-participation exams, it's interesting to go back and look at the monographs that set up the pre-participation exam standards. Why do we do pre-participation exams? And it's primarily to understand or identify diseases, conditions that could progress to sudden death in young athletes. That's our main reason for doing our pre-participation exams. If we look at the causes of sudden death, the largest, of course, is accidents. But in those that we may have some medical ability to affect, cardiac or sudden cardiac arrest is the leading cause for death in our athletes. Interestingly, it's larger than homicide and suicide combined. It's also larger than heat stroke, sickle cell, and concussion combined. It truly is the largest medical cause of death that we have some ability to influence. So we have to ask, do our current practices really accomplish the mission of preventing sudden death? And I think with all of the athletes that we see dying nationally, we'd have to say that no, we really are not finding athletes effectively, and they are dying. And I think the next was a poll, Sarah, of how many of you have been associated with or within your institution have had a sudden arrest?
Okay, the poll is launched, and people are voting. Give it a minute.
When we were at the trade shows, I'm always amazed at how many people come up to us with experiences or close associate experiences with sudden death. So how does it look, Sarah?
It really is amazing. We've got 85% voted, so I am going to give it one more second here. I think that's about it. I'm going to close it, and I'll share the results.
So 12%. So that's a lot of deaths or arrests that have happened within the schools. Thank you, Sarah. Let's continue on then. So let's look at the prevalence of abnormalities that are resulting in death and look at it in terms of sport and ethnicity. Interesting, sudden cardiac arrest is highly stratified by gender and ethnicity. A recent study by Dr. Harmon here at the University of Washington found that overall in the NCAA, where we have a really accurate understanding of all the participants and all the deaths, that about 1 athlete in 43,000 per year dies of sudden cardiac arrest. But it's quite variable. In men, 1 in 33,000, and in women, 1 in 76,000. Men are about twice as of greater risk than women for sudden death. It's also heavily stratified by ethnicity. African Americans are about 3 times more at risk than Caucasians. It's also stratified by sport. Sports such as basketball have a death rate of about 1 in 11,000 participants per year, and decreasing from there to swimming, lacrosse, and cross country. Sports where the heart is at a constant, perhaps high, but constant rate are far less at risk than sports that have large adrenaline surges that result in triggering cardiac events. If we look at men's basketball in Division I, African American and Caucasian men have a death rate of about 1 in 3,000 per year of play. But we think about these athletes, and they've been playing or play college ball for 4 years, so they have a 4-year exposure. Their death rates in the NCAA for Division I are about 1 in 800 per year. It's a pretty startling rate of death in these young athletes. We have an urgent need to identify at-risk athletes in what I think of as the high adrenaline sports, the activities that where we go from a standing stop to a full charge and a stop again that creates surges of adrenaline that appears to be serving as triggers for these cardiac arrests. In the prevalence, we've screened tens of thousands of athletes using CardeaScreen over the last year. When we screen 1,000 athletes, what we typically find is 20 to 30 athletes have what we consider to be truly abnormal ECGs. The abnormalities may not result in sudden death, but they are definitely things that will probably impact the health over the course of their life. As we all know, cardiovascular problems continue to be a leading cause of death in America, and early detection of these conditions can lead to better health management over their life, and in many cases we've seen add decades of productive life to an individual that might otherwise have heart failure at a relatively young age. Out of the 35 or so confirmed abnormal ECGs, there will be additional follow-up diagnostic tests of echo, stress, electrophysiology studies, and we routinely find 2 to 3 athletes out of 1,000 that have truly life-threatening cardiac conditions that definitely need some form of attention. A lot of work's been done recently on autopsy within the NCAA athletes, looking at what are the causes of sudden death, and this pie chart shows that. The largest cause of sudden death is this area on the bottom of the pie chart where the heart is actually structurally normal. There's no apparent abnormality on autopsy. We believe these to be sudden deaths that are related to electrical abnormalities in the heart, particularly Wolff-Parkinson-White, long QT. In other parts of the world, Brugada, not so much in the U.S. Many of these are related to repolarization abnormalities as the heart prepares for the next heartbeat. There's also quite a bit of disease around hypertrophy. We've heard about, historically it's thought to have been the largest cause of death in what we might think of as over-muscular heart genetic disposition towards hypertrophy. Also a nasty disease, arrhythmogenic right ventricular cardiomyopathy is a common cause of death. There's also other abnormalities that do not have electrical signature, problems with the size of the aorta, and misplaced coronary arteries that are more detectable on an echo. So now that we've seen a little bit more about the prevalence of cardiac arrest in athletes, what is it about our current pre-participation exams that is not allowing us to adequately identify at-risk athletes? Part of our physical exams is the American Heart Association recommended history of questions. What kinds of things have happened to the athlete in recent years? Typical questions include, do you have chest pain on exercise or discomfort? Have you ever lost consciousness or experienced syncope, particularly during exercise? Excessive shortness of breath, and so forth. Or have there been any family members at a young age that have died unexpectedly? The percentages of positive responses are alarmingly high, ranging from 6-7% to 11-13%. Overall, we find that a third of all athletes answer a positive response to one or more of the AHA questions. It's very difficult to draw a whole lot out of this. It has very low sensitivity and very high false positive rate. Obviously, 33-34% of the athletes are not really at risk. The American Heart Association questions are frankly almost useless for identifying athletes at risk. On the other hand, the physical exam has fairly low positive responses, heart murmur being the largest. Abnormal femoral pulses and Marfans are fairly infrequent. Any positive physical exam abnormality runs at about 3% nationally. So it has a very low abnormal rate, which is great, but it also provides only about 14% detection of abnormalities in youth. So the combination is between the physical exam and the history questionnaires is that we miss most athletes. In fact, commonly, most athletes are totally asymptomatic, and the first sign of cardiac abnormality is a sudden cardiac arrest. Good question is, what's the sensitivity of the ECG? What can we actually find? We can actually do a pretty good job. We can't find everything. We're not going to find the things that are truly structural that don't have an electrical signature. But overall, the current thinking is that we can find about 65% of the conditions that lead to sudden death. I was at a conference the other day and understood that it was potentially as high as 80%. Game changer. What is the Seattle Criteria? Perhaps some of you have heard about this. The big concern about using ECG has historically been a very high false positive rate. The historical average has run 10 to 15%. We know in many cases it can be as high as 25%. It's hard to justify implementing an ECG screening for athletes if our false positive rates are this high. There's an associated high cost to follow-on diagnostic tests to rule out false positives. It's emotionally distressing to an athlete and family to think they have some significant cardiac condition only to find out that they don't. And there have not historically been accepted ECG interpretation standards for reading an athletic heart. All of these things have been valid concerns on why an ECG may not be appropriate. But research in the last 2 years has made a dramatic progress in these areas, and I'm excited to say that I think we can do dramatically better. The first of this in the U.S. was the paper that we put together, my partner and colleague, Dr. Froliker at Stanford. Vic does all of the screening for the incoming Stanford athletes as well as for the 49ers. I was a co-author on this paper, published in Circulation, one of the leading journals for American Heart Association, on what are the right criteria to be using for interpreting electrocardiograms of young athletes. A good cross-section of cardiologists nationally and internationally put together the criteria on each of the little wiggles on ECG. What do they mean? Which ones are really important for athletes? One of our co-authors, Dr. John Dresner at the University of Washington, coach for the UW Huskies and also a team doctor for the Seahawks, convened a follow-on conference here in Seattle in 2012. And because of that, it was dubbed the Seattle Criteria. Again, a great cross-section of doctors from around the world. Italy has been a leader in cardiac screening, some of the leading figures from Italy. Dr. Sharma from England is the leading cardiologist for sports in England. And out of this came a series of papers and publications published in the British Journal of Sports Medicine on what are the right criteria to use for screening young athletes. Along with the criteria were a suite of papers on how to manage these athletes so that doctors have a good pathway forward when things are found that are concerning. So with the Seattle Criteria, we've seen in the previous slides that we have false positive rates that run to 10 to 15%. With the Seattle Criteria, how do we do? We're just finishing a major study sponsored by the NCAA. We collected ECGs from 5,000 athletes in Division 1 through 3 schools and 36 total different schools participating across the country. All of the ECGs were overread by the cardiologist here at the University of Washington. We find using the Seattle criteria that the abnormal rate for men is 4.5% and women is only 2.5%, for an overall abnormal rate of 3.6%, versus a historical for ECG of 10 to 15%. There's been a dramatic improvement in our ability to accurately identify kids at risk. We then look at the results from these studies and all the follow-ups that were done to further diagnose athletes that do have true faults or have true conditions. We found that the history exams only find 0.2%, have a positive predictive value of only 0.2%. The physical exam is 2.2%. The ECG is 8.9% in terms of positive predictive value, 4 times more accurate than the physical exam. Indeed, one can make an argument that the Seattle criteria is truly a major advance for ECG effectiveness. The criteria will continue to evolve. There's a follow-on conference that will be held this coming February. We expect further refinement in the criteria. There's been a lot of interest in something called skinny Q waves. In older adults, well-developed Q wave is a sign of a myocardial infarction or a previous heart attack. It's been included in the criteria for athletes, although on follow-up testing we're not finding that the skinny Q waves have diagnostic significance. And they compose about 30% of the current abnormal rates. So I'm excited. I think after our February conference we may be able to bring the ECG abnormal rate down to less than 3%. One could argue, I think, argue strongly that if you wanted to do a better job of finding athletes that were truly at risk, using the Seattle criteria actually significantly surpasses history and physical exam in identifying at-risk athletes. I don't think anybody would do it, but you would actually do a better job of dropping history and physical and adopting just an ECG. So how easy can we add an ECG to our pre-participation exams using CardeaScreen? Well, in the NCAA study of 36 D1 schools, in our first year we participated with Division I schools and expanded in the second year into the D2 through 3 schools. Out of those, quite a few of the colleges and universities have adopted CardeaScreen for their annual use. So quite clearly, people are being very successful in the college and university environments in using ECG screening. ECG adds 1 station to your pre-participation exam of your athletes. The procedure adds 10 electrodes, 6 across the chest around the heart, and 1 each on each arm and each leg. CardeaScreen has a screen for entering the basic demographic information, the name, age, ethnicity, gender. We do include the American Heart Association questions in the context of an abnormal ECG. It's quite helpful to the doctor to know if there have been other symptoms, if the athlete has symptoms that coincide with the conditions that we're seeing. We record 16 seconds of data. It's a fairly short test. We save and print the ECG. The total material costs are less than $1, and it takes about 6 to 8 minutes to add the ECG into your PPE. It's a fairly short test, easy to do. Training. We routinely do high school screenings here in Seattle with an organization called Nick of Time Foundation. It's probably one of the national gold standards for how to screen high school kids in a gymnasium environment. We'll come in the night before and set up. And we routinely use volunteers for the recording of ECGs, maybe family members, parents, EMTs, and sometimes clinical staff that volunteer their time. There's no special medical skills that are required, and we routinely train the people that are doing the ECG recording in about 10 minutes of training. So it's a fairly easy process. The overreading of the ECG should be done by medical staff, and the record should be read to the Seattle criteria in order to improve your detection rates and keep a low false positive rate. And there's a continuing medical education program, 6 hours, 6 one-hour classes that's now available through the British Medical Journal that's been done as part of the Seattle criteria. And so if your doctors are interested or concerned about how that they overread the records, here's a great class where they can get their CME credits and feel comfortable in their ability to overread the ECGs. And finally, why is CardeaScreen the right choice for ECG screening for your young athletes? Here's a quote from the executive director of Nick of Time. I mentioned earlier, Nick was a young athlete who died of hypertrophic cardiomyopathy, football player. His mother started this foundation here in Seattle, Nick of Time. They are a major user of CardeaScreen in their high school screening programs. And what Darla reports back is that the volunteers just love the simplicity of use. The doctors love the high-quality tracings and the very accurate interpretations. CardeaScreen fully embraces the Seattle Criteria. The handheld device is easy for the users. I think most of you that have been involved in ECGs are aware of the large boxes on big rollers that you have to push around. It's a small handheld device that talks with a Bluetooth radio to a standard Windows PC. It's quite easy to use. And if you're doing screening programs around your region, perhaps in an outreach program or in a nurse's office in a high school environment, it's an easy device for you to set up and use. A few quick slides on the actual application. The patient demographic screen starts with information about the name, gender, because gender plays a role in the criteria. There's some criteria that are different for men versus women. Ethnicity is also quite important. There are conditions in African Americans that are normal that would be considered abnormal in Caucasians. Birth date, so we have the age information, which can also play a role in the criteria, and so forth. All of this can also be customized, so if there's things that you want to record that's important to your program, you can customize these fields and record the data that's important to you. Next follows American Heart Association questions. These are just little radio buttons, so you can click on or off if the athlete's had chest pains or passed out or has a heart murmur or family history. And if you wish, you can also record any observations from the physical exam or any particular notes that are relevant to this particular athlete. This takes just typically a couple of minutes to fill in. You can click record, and immediately the ECG transmitter beeps and starts transmitting data from the patient to the PC. We record for 16 seconds of data. The standard ECG is a 10-second recording, but what we found in our early research, of course, and no surprise, is that athletes have very low heart rates. And a 10-second recording often doesn't record enough beats to get a great estimate of the heartbeat, all the waveform shapes. And so we extended the recording time by 16 seconds, which gives us a much better quality beat estimate, better measurements, which lowers our false positive rate and improves the diagnostic accuracy. The screen will just play the data. If there's noise on a lead or if the athlete's not lying still, you can direct them to lie still and relax fully. Wait until you have a full screen of ECG data, and then just simply click the stop button in the top left corner. Immediately the ECG is analyzed and presented with a standardized 12-lead ECG for the doctor's review. The top line will show the patient information. The middle section of the report on the top left here will show any abnormalities that have been found in the ECG, pointing the doctor to where they should look more closely. For conditions that are known to be associated with risk of sudden death, we also add a warning to the ECG that it'd probably be a good idea to refrain from strenuous activities until there's some follow-up exams. And then also very helpful to the doctor, if there's been findings in the American Heart Association or the pre-participation exam findings, those will be here. In this case, this athlete had on pre-participation exam a heart murmur. So the doctor has together in one place everything that he or she needs in order to make an interpretation. There are also a suite of tools in the application for doctors to do confirmation, overreading of the records. We have many institutions where the training room and the doctor's offices are all connected on a shared server, so the doctor can overread the ECGs at their desk at their leisure, and the training room can add this simply into their process. It just takes 4 mouse clicks to record an ECG, print, and save the record. It's very simple to use. As I said earlier, it only takes about 10 minutes to train somebody on how to collect an ECG. The Seattle Criteria is a key feature. I really can't emphasize enough the research that's going on right now on improving the diagnostic accuracy, and that's embodied in the Seattle Criteria. CardeaScreen is the only ECG device that implements the Seattle criteria. And we've had a number of doctors telling us that it's like having a consulting cardiologist previewing each ECG. The unique system features, I think I've mentioned, the very high quality data is recorded for 16 seconds to overcome the low heart rates typical of athletes. There's a Bluetooth connectivity to a standard Windows PC. The clinical staff that use the device just love not having the large box that's easy transport and the wires that drape from the box to the patient. It unifies together onto one piece of paper or electronically onto one screen all the key history and physical exam observations with the ECG. CardeaScreen is the only device that implements the Seattle criteria. We're currently running at a false positive rate of about 2%. There are some areas where we want the doctor to make a judgment call, and rather than miss something, we'd rather slightly overcall. So we're calling it about a false positive rate of about 2% versus every other device on the market today runs at about 10 to 15%. We do support the physician overreading. There's no additional software required. In many ECG systems, you need to spend $20,000 or $30,000 for additional software if the doctor wants to overread the records electronically. And it's really designed for sports medicine and pediatric clinic environments. There are tools for sharing data between the cardiologists and the doctors, tools for exporting and moving data in HIPAA-secure ways over the open internet that help you make this easy to integrate with your medical staff. It's truly designed for cost-effective screening. We originally designed this for my partner colleague, Vic Froliker, down at Stanford for his use with the Stanford athletes and 49ers. And the focus has been on how do we make this effective? How do we find athletes at risk in a way that's easy for you guys to use? Sports cardiologists, we recently actually had a shootout down in Mobile, Alabama. We ran CardeaScreen against a competitive device. The overreading pediatric cardiologist, this is her quote, loved the machine. They ran a couple of kids on both. The other machine would spit out a paragraph of abnormalities. This is the typical 10 to 15% false positives. Cardea only picked up the true abnormalities. There were only a few abnormal ECGs. I loved using it. Hope to use it again. Think this is going to be a big help for people doing screening for young athletes. And also a promise. Vic and I are really passionate about screening young athletes. This device has had impacts on many people that are close to us. We're quite dedicated to continuing our research efforts and being leaders in ECG technology, focused on accurate and very cost-effective identification of cardiac abnormalities in young athletes. We are participants in the research. We will be participants in the Seattle criteria follow-up meeting in February. And as research continues, because this is a PC-based device, we were able to provide no-cost updates to CardeaScreen algorithms that improve accuracy as the research continues. I think, Sarah, at this point, we're going to turn it back to you, and I think you've been collecting questions along the way.
Yes, thank you. So if anyone has questions, please type them into the questions field, and we will address them with Dave. The first question I got, and I wondered the same thing myself, and it's about screening female athletes. And
Sure.
Just how much extra time does it take? Is for proper setup or draping, things like that. And I know you have some experience with that, Dave.
Yes, we do. In the college environment, depending upon your setup, and it's common, I think, for the physical exams, particularly for the female athletes, that happens in a private room. And so in that environment, there's really not much of an issue. When we do the high school screenings, we do set up a men's and women's side. We do provide hospital gowns for the women. The electrodes do surround the breast, but we find pretty commonly that it's easy to place the electrodes around a sports bra. But we do obviously set up for privacy a women's side and provide gowns.
Yeah, that makes sense. Good. And the next question is from Sarah, and her question is, how much does a CardeaScreen portable device cost?
Yeah, good question. I should have mentioned that. Yeah, so we sell the device. We list the device at $2,850. It's obviously available through Sports Health, School Health. With that, it couples to a standard Windows PC. Most people have a PC, but if you need to get a PC for this, they're typically run $350 to $400. Provide the PC with adequate power, more than enough power to run the CardeaScreen application. Most ECG devices start at about $4,000 and go up to $10,000. So not only is it a great device, it's focused on the mission, provides tremendously good ECGs, but it's also probably the best priced device in the marketplace.
Yeah, it sounds like a good solution for schools at that price point.
Yeah.
Great. And the next question I have is from Brian. And he asked, how often should athletes get screened? Is this a yearly thing or just once in a lifetime?
Great question. Great question, Brian. We recommend that in high school or college that the athletes are screened on entry into the programs. And then I would recommend that the high adrenaline sports athletes are screened at least every other year, if not every year. The hypertrophic cardiomyopathy can emerge. It's a genetic predisposition, but it can emerge over the course of 1 to 2 years. And an ECG that's normal and can become abnormal over a couple of years. And so I think screening of the lower risk athletes on entry into your program is fine, but on the high risk programs, high risk athletes, I would recommend probably at least every other year that they have a follow-up ECG.
Great. And then the next question is from Daryl. He asked, what is the number of exams that may be ran on a set of batteries and a set of contacts?
Sure.
Is less than $1.
Okay. Yeah, so the ECG transmitter has a rechargeable battery. The battery has, on a single charge, will do about 200 ECGs. Typically, will handle the clinic for a full week. And the transmitter is perfectly safe to use plugged in as well. So there's ample capacity to run a long program with the system, way more than you could ever possibly do in a day. The electrodes typically run nickel apiece. There's a few outlets where they might be slightly cheaper than that. We can provide links to those if you wish. We do not provide the electrodes. They're readily available on the internet. We put 10 electrodes on an athlete, so it's 50 cents typically for the electrodes. And then we print to a standard laser printer. There's no need for special paper, as is typically used in many ECG devices. And so the paper or the printer costs are probably a dime a record, quite low. The total cost to do a test for materials is less than $1 an athlete.
Okay, great. Let's start explaining that. And then Donna asked if the accessories for CardeaScreen can be ordered through Sports Health, and I believe the answer is yes.
Yes, of course. Yes. Yeah, there are.
I know we carry one brand of electrodes right now, but our product manager, I believe, will be adding some additional electrode options to our selection as well.
Great. There are two kinds of electrodes. There are some that are used in hospital settings for long-term monitoring that have a little snap-on button in the middle. But for the athletes, we use these tab electrodes, and the clips on the end of the cables for CardeaScreen will clip onto either of those two kinds. But it's clearly much more cost-effective to use the tab electrodes.
Okay. And the next question is from Jeff, and he asked how much extra time are PPEs going to take per athlete due to the screening lasting 6 to 8 minutes?
I'm sorry, I'm missing that question because the pre-participation exam takes about 6 to 8 minutes, and that's about how much additional time needs to be added to the total cycle for each athlete. So that's the time from the time the athlete comes to the table, takes off the shirt, gets on the table, we put in the electrodes, add the patient demographic information, record the ECG, save it. The athlete has the electrodes removed, and they're on to the next station. It's typically 6 to 8 minutes.
On top of the, whatever they would normally do as part of the PPE.
Correct.
Okay.
Yes. Yeah.
And,
in the college environment, it's often done on a team basis. So, one day the basketball team may come in, the next day the football team may come in, and so it's my experience has been it's been generally pretty easy to work in one more station into that mix.
Okay, great. And the next question is from Denise. And this is a great question as well. Do you screen younger athletes? She's asking about middle school. She had a young athlete with prolonged QT interval diagnosed and worries about other young athletes. Is it worth it, or would it not show up until older? I think she's asking. Because we're screening that middle school population typically.
Yeah, long QT will be there probably from the start. It's often thought that it might even be an issue for sudden infant death. The prepubescent heart changes through puberty. The Seattle Criteria is currently designed for post-puberty, so 14 and above, and up to athletes that are in their late 30s is the appropriate range for using the Seattle Criteria. CardeaScreen is perfect for recording the ECGs for younger kids. The tracings are great. The abnormalities that are found are true differences in the waveform. But the interpretation of that needs to be done by a pediatric cardiologist for a young child, because there needs to be a judgment call on where they are in the progression through puberty. So yes, you can use the system, but I'd just be a caution that a prepubescent child needs the care of a pediatric cardiologist to fully and accurately read the ECG.
Great. Those are the questions that I have from the audience so far. Did anyone else have any additional questions? Let me give just a minute. I think Dave, you had mentioned that you can screen about 500 athletes in 6 hours if you do set up the day before. Is that pretty accurate for large screenings?
I think you can do it substantially more. It depends upon how many stations you set up. For the foundations here in town, we set up 12 stations, 6 on the boys and 6 on the girls. Staffed largely with volunteers. We do have on-site doctors that come in and provide an overreading consultation service. And with that setup, we can routinely screen 400 to 500 athletes.
That's amazing.
One of our good customers in the Chicago area has 18 systems, and she goes to some of the Division I schools and will set up. And with 18 systems, she can screen 600-700 athletes in a day, and she does the whole thing electronically with doctors overreading the records, basically in real time as the athletes come off the table. The doctors are overreading the records electronically.
Wow, and you said a layperson can be trained to do the screening. Is that correct?
Correct. It takes about 10 minutes. Takes about 10 minutes to train a volunteer on how to place the electrodes and how to enter the data and click the right buttons.
Okay. Great. I have a few more questions coming in. There's a question from Abigail. She was wondering how prevalent sudden cardiac death is in children under 14. Do you know the answer to that?
I don't have a good answer to that, and that's a great question. It's at least comparable to what we're seeing in the older population. There have been some recent papers suggesting that there may be a Darwinian effect going on, that we're losing a lot of kids at an early age that we're not detecting. So by the time they get to high school and college, the highest risk athletes have already been lost. But that's a great question for follow-on research. There was a recent paper published by Vicki Vetter, leading cardiac pediatrician who's been a participant in the Seattle Criteria. And Vicki would argue strongly for ECG screening for all kids at all ages.
Good. And then so we have some, there's also some questions about how do you find a physician or a cardiologist to oversee your program and do the readings? Like, for example, if a high school started a screening program, how would you recommend having an expert review those findings?
Yeah, I think one needs to network in the community and find that champion who recognizes the issue and the risk and is willing to help support this. One of the things we found in the outreach programs that the great thing for the cardiologists is they can they can provide this service. They may not make a lot on the service, but they then get the referrals when the kid needs some follow-up work. So it's actually a strong business opportunity for the doctors or the hospitals that participate with you. So it's kind of a win for them. They get good brand recognition and awareness in the community for the service they're providing, and they tend to grow their business because out of every 1,000 kids, there's 20 or 30 they're going to look at more closely, and 2 or 3 that are going to need some serious attention. And then, as I mentioned before, we have online that British Medicine journal of the training for the Seattle Criteria, so the doctors can spin up on the right criteria to be using in conjunction with CardeaScreen in order to read the records.
Okay, great. And then Abigail is kind of on that same topic, but she asked how the electronic reading works.
How the doctor?
Is it like a pass-refer, similar to other, screenings that you might do in a school, like a vision screening?
CardeaScreen will provide an interpretation, automatic interpretation based on the Seattle Criteria, and then the doctor can review that either on paper if you choose to print it out, or you can transfer the data electronically, and the doctor can overread the records at their desk with the electronic data. So it can be done either way. It's very similar to other kinds of diagnostic tests where there is some form of output that the doctor has access to and can review.
Okay, great. And I have another one more question from Sarah, and she said, how would she, as an athletic trainer, I believe Sarah's an athletic trainer from her question, if she wanted to do this with her athletes, how would she get trained? Would she take that continuing education course? Or who would she contact to receive training once she purchased the device?
Sure. So we would help her with the training. We are actually putting together a video right now. It'll be available later this year. It'll be about a 7-minute video training on how to apply electrodes and how to successfully record the ECG. There's also an operator's manual, but I think the video will be a great avenue for people to quickly spin up on how to do the ECG. We currently have a video on our website that provides information on how to place the electrodes, but this follow-up video will provide details on the complete process from meeting the athlete to putting the ECG on their clipboard as they move on to the next station. And then for their doctors, the British Journal of Medicine article and the Seattle Criteria, we can point you in that direction. That CME class is actually free. It's a 6-hour class on the Seattle Criteria, and doctors get their continuing medical education at no cost for that class.
Oh, that's great. Okay, did anyone else have any questions? I think that I covered everything that came in so far. I think those were really great questions. We covered a lot.
They were. I appreciate them. They were really awesome.
Yeah. So just a few things to wrap up. When we finish the webinar, we do ask you to fill out a very brief survey. We would love to get your feedback on how we did today. And I just want to remind you that we will send a follow-up email to everyone December 1st or earlier, and that will include the link to the recorded webinar. You will get a certificate of attendance from us that says you participated in today's webinar. We'll provide you a link to download the slides. You can review those along with the recording. And also, we'll include a link to request assistance from a sports health representative if you would like to just, get some help with the purchasing process or have questions about pricing or how many units you need. They can assist you with any of those types of questions. And I would also just really like to thank Dave for spending his afternoon with us and preparing such a great presentation. I know I learned a lot, and I hope everyone that attended today did as well. So I just like
I want to thank everybody for participating as well. It's a pleasure to do this. I enjoyed working with Sarah, and I appreciate all of your help.
Great, and Denise just said thank you for a great webinar, so we appreciate that feedback already, Denise. So yes, please take a moment to fill out that survey, and We will be conducting future webinars from Sports Health, so we hope you will join us again in the future. And with that, we'll wrap up for today. Thank you, everyone. I hope you have a great afternoon and a happy Thanksgiving.